Okay, so dear chair, dear audience, I'd like to present to you my PhD work in the few upcoming moments. My name is Hanna Gizaw, and I work as a resident doctor at Semmelweis University at the Department of Obstetrics and Gynecology. And I'm doing my research work under the supervision of Nándor Ács and Boglár Kapvető. My vision is to provide better antenatal care and higher quality of life for the newborns, and my mission is to provide evidence on the optimal paternal age for having children. Currently, I have two ongoing projects on the same topic. In my first project on a national level, and in my second project on a worldwide level. So investigating the influence of paternal age and on the development of congenital anomalies in the Hungarian population between 1918 and 2009. And this is a population-based study. 4.5% live birth involved congenital anomalies in Hungary in 2021. In 2000, 16% of the fathers were under the age of 25 when their first child was born, and by 2016, only half of the fathers were at that age. 5% of the fathers in 2016 were at the age of 45 or more at the birth of their first child. So we can say that the age of the fathers at the birth of their first child increases. And there is no consensus on the optimal paternal age for having children. So my aim is to identify high-risk paternal age group in the Hungarian population for congenital anomalies. My clinical question: what is the ideal paternal age to minimize the risk of congenital anomalies? And we are taking into consideration the newborns, we are comparing the age of the fathers and looking for structural congenital anomalies as outcomes. And my hypothesis is that there are paternal age that can be associated with increased incidence of congenital anomalies in the newborns. My clinical research implication is to increase childbearing awareness and lower the incidence of congenital anomalies. Let me introduce my study design. Our data was collected from the Hungarian case control surveillance of congenital anomalies, and the total birth count for the same time period as a function of paternal age was collected from the Hungarian Central Statistical Office. The study period, as I've mentioned, was between 1980 to 2009, and during that time there were more than 30,000 cases with birth defects and 3 million live births in Hungary. Okay, so let me show my results there. On these figures, there is a light gray column. This is the optimal 10-year range for each anomaly. We have analyzed each malformation individually. And according to that, we can say that we saw an increased risk at advanced paternal age when we took into consideration genital organ malformations, circulatory system malformations, urinary system malformations, cleft lip and cleft plate, while we saw an increased risk at low paternal age at musculoskeletal system malformations. And there was a U-shaped relationship when we looked at nervous system malformations. So it means that not only the advanced paternal age, but also low paternal age was associated with higher risk. And there were congenital anomalies where we found no association, just like in digestive system malformations. And due to low number of cases, there was again no association when we looked at eye, ear, face, and neck malformations and respiratory system malformations. Overall, we can say that we came up with a statistically significant but clinically not relevant result. We made an additional analysis taking into consideration fathers above the age of 40. And with the malformations there, we came up with significant results. And overall, we can say that non-chromosomal malformations together had a higher chance to receive above the age of 40. The strength of this project is the large national sample, the comprehensive registry design, and the novel statistical modeling. But of course, we have limitations, the retrospective use of registry data, and the residual confounding effects like paternal smoking, alcohol consumption, genetic background that could not be excluded. Sorry. So my conclusion there that paternal age correlates with the non-chromosomal congenital anomalies. Overall, the optimal paternal age for having children is between 19 to 28 according to our data. And there is a 22% higher risk for the newborns to receive non-chromosomal congenital anomalies if the paternal age was above 40. So my implication for practice would be to specify screening methods and optimize family planning. And the implication for research would be to study biological background, and more studies are needed with larger sample sizes and from different regions in the world. This is the status of my first project. We submitted it. And I'd like to talk a little bit about my second project as well, investigating the influence of paternal age on the development of congenital anomalies via a systematic review and meta-analysis. Worldwide, 2 to 4% of live births involve congenital anomalies, causing significant medical, surgical, cosmetic, or lifestyle consequences. And there's an increasing number of fathers at the age of 40 or more. And not only high, but also low paternal age can be associated with an increased incidence of congenital anomalies. And currently, there is no consensus on the optimal paternal age for having children. So my aim is to investigate the association between paternal age groups and the incidence of congenital anomalies. My clinical question there, are there paternal age groups with an increased incidence of congenital anomalies? And we are using the same work frame, so the population is the newborns. We compare different age groups of fathers and looking for structural congenital anomalies as outcomes. And my hypothesis is that there are paternal age groups that increase the incidence of congenital anomalies in the newborns. We carried out a systematic search in 3 comprehensive databases, and with the search key below, we came up with almost 10,000 hits. And after the duplicate removal, the title and abstract selection, we came up with 34 eligible full texts. From these full texts, unfortunately, we could only use 7, since these 7 use the same age groups, same reference age groups, and use logistic regression as statistical modality. And let me show my results there. On the left side of the plot, you can see the age groups and the malformations that we took into consideration and the ORs. And according to that, our significant results are that spina bifida occurred more commonly below the age of 20, while the age between 30 to 34 remained a protective factor for receiving cleft lip and palate, while cleft lip and palate occurred more commonly between the age of 45 to 49 and renal agenesis over the age of 50. I'd like to add an extra figure there with the pooled odds ratios with the age groups that we took into consideration, and there is a logical U-shaped relationship between the age groups and the occurrence of birth defects. The strengths of my second project is that we included only population-based studies. We carried out individual analysis for each anomaly. There were a large number of patients, and the incidence of malformations aligned with this existing literature. And the limitations there, the different age categories, the inconsistent outcomes, and heterogeneous reporting, why we had to exclude many studies, unfortunately. Restricted to specific regions for the analysis, especially for America and China, and there was a limited number of studies that we could include. So the conclusion is that those under 20, between 45 to 49 and over 50, are at higher risk for having babies with structural congenital anomalies, and overall the incidence of congenital anomalies exhibits a U-shaped pattern. The implication there, again, to specify screening in certain age groups and optimize family planning. My implication for research is to study biological background, and more studies are needed with larger sample sizes and from different regions in the world. This is the current status. With my second project, we are at the manuscript writing phase. And I have already submitted my first project and looking forward to submit the second one until the end of summer. About my additional activities, I'm trying to help with educating the first-year medical students, and I'm taking part in clinical trials as well. I'd like to close my presentation with a quote from Kurt Vonnegut, "Science is magic that works." Thank you for your kind attention as a last presenter.
Hanna, can we jump into the introduction part? So, later you report that the rate of congenital anomalies is between 2 and 4%. Now, in Hungary, the Central Statistical Office reported 4.5%.
In 2021, yeah.
Yeah, and in the cohort of the database, you showed some absolute numbers, 32,000 or something.
32,000. Yeah. Sorry. Yeah, there.
Yes, here. Collected data, 32,000, while during this time there was 3 million live births. So if I make if divided these two numbers, then comes out 1%. So if I would a reviewer, I would ask you that, okay, guys, but this 1% rate or detected rate of anomalies with this database probably did not cover the entire Hungarian population. What is about the other 2% or 3%?
Well,
what would you answer to the reviewer?
But it's a great question, and
I want to help you.
But yeah, it's
such a type of question.
Yeah, it's a great question. Maybe it was in 2021 when there was a higher risk for congenital anomalies, and of course this number contains, that we collected from the Hungarian case control surveillance. It's for only structural, so no chromosomal anomaly were involved.
Oh yeah, okay.
And of course, the Central Statistical Office gives us big data, including the congenital anomalies as well. So on this first slide, it rather like to be a wow effect that, oh my God, there are many babies with congenital anomalies.
Okay, so it could be some selection bias that the database did not collect all the data, and it would be very important. The manuscript already was sent.
Mm-hmm, yes.
Okay.
We use this ICD classification, which has a code for each abnormality. Mm-hmm. So it was excluded. There from those that involve the chromosomal ones.
So it could be not a big problem if the data collection not covered every cases. It must be proved that there was not a systematic selection bias in it, so that these 32,000 babies are representative for the whole Hungarian population. Otherwise, it's hard to protect the results.
Hanna, thank you and congratulations for your presentation. I just would like to notice that this date from 80
yeah.
Till 2009, if I remember very good. I think this date is very special date because we have a big exposure in 1986, and it could affect the congenital malformation.
Yeah, I totally agree. That's a great point. We should need enthusiastic PhD students to follow the data collection. Yeah.
Okay, thank you.
Thank you for the presentation. I think it's really interesting because until this day, the literature usually focuses on the female age rather than the male age. But do you think it's right to only look at one side's age? Don't you? I feel like it's more important to see the combination of the ages, do you think there might be a compensation if the male is, I don't know, older than 40 and the female is 20? Or do you think, or would they potentiate the bad effect if they are both older than 35 or 40?
Yeah, I'm sure this is one of the biggest confounding factor, the maternal age there, next to many others. But yeah, it would be very interesting to study the paternal and maternal age together, since the maternal age is a well studied field. Yeah.
Thanks a lot for the presentation. Well done. Obviously, the setting is very of your study is very vulnerable to confounders.
Yes,
because
exactly.
It selectively looked at one risk factors, and it's already been mentioned maternal age as another potential important factor. What would be the other most important 2 to 3 potential confounders in your studies aside from maternal age? What would you think of?
The genetic factors, the paternal smoking, alcohol consumption, education, socioeconomical status. These maybe.
It's a lot of lifestyle factors, right?
Yes.
Do you think there's any strategy to kind of address these lifestyle factors? What would come up your mind? Because that is very likely one question that you will get from a reviewer, right? That they will say, okay, you need to correct, or what are the other confounders, and you can identify them. What would be a strategy to tackle that in the project? Could you think of any strategy to tackle that in the project to kind of rule out these other risk factors?
Well, exactly no, but unfortunately in this database we have very little information about these confounders, so it's very hard to answer this question, but honesty is the key, I think, there, that for example, out of these 30,000 anomalies, we barely have 1,000 cases where we have the information regarding these confounding factors. So it's hard to.
For example, you can try, if you have access to one of the larger hospitals where you get the data from, or the data set from, you could try to get maybe information on a broader aspect. So get other confounders. So for example, if you get for 1,000 or 2,000 of these patients, other additional factors where you know the maternal age, where you know the lifestyle from a questionnaire or so, then you can run kind of a short confirmatory analysis and maybe balance that and weigh that and see if other factors are important. That would be maybe one option. If you want to take it on a prospective level, what would be your scenario that you could think of a prospective setting to address this question? Would you kind of go for a randomized controlled trial, or would you go for a prospective registry, or what would be your concept to kind of rule out these other confounders? What could you think of?
Yeah, maybe both. I think the main thing is that we should register the paternal factors during the pregnancy care first. Not only when women comes in the hospital to give birth, but previously. So I think that's the key, because in night shifts or sometimes there are many cases at the same time, and we do not have the enough time to collect all these data. So maybe I would put an emphasis there and start the collection also during the pregnancy care.
Yeah, so mostly you've covered what I was going to ask anyway, but could you give like a general description of what a confounder is, and also if there were any confounders that you actually could control in this database? Because I think we've talked a lot about, those that you couldn't, and yeah.
These are variables that can affect both the exposure, so the paternal age, and also the outcome. So they're the structural congenital anomalies.